Welcome to the webinar Thriving in Substance Use Disorders, Service Delivery in the Post-COVID Era. My name is Andrea Havler, and I will be helping with facilitation today. Before we start, I want to thank again all of you for receiving this webinar so well. As you know, this 8-part webinar was created by the Center for Substance Use Training and Telementoring, CSTAT, a division of the Be Well Texas Institute, in collaboration with the Texas Health and Human Services Commission, with the intention of training our behavioral health professionals on ways to manage, mitigate, and communicate during pandemics such as COVID-19, always, of course, as it relates to substance use disorders. So to that end, we brought together a group of experts, addiction specialists, immunologists, and others to explore and discuss that intersection between substance use disorders and COVID-19. So today we have a very special guest with us. We have Dr. Michael Mackert talking about communications during health emergencies. Dr. Mackert is the director for the Center of Health Communications at the University of Texas at Austin, and he is also a professor at the Department of Population Health. And his research is focused mostly on using new digital forms of communication to better relate or communicate to populations who are low or who have little health literacy. Is that correct, Dr. Mackert? We are so pleased to have you. Did I say right?
Yep, nope, you nailed it.
Thank you so much for being with us today. It's a pleasure to have you. And before we start with your presentation, I just want to remind our participants that this session, as always, is being recorded for later distribution. You can find it later at our Be Well Texas YouTube channel. And please be on the lookout for information on how to obtain CMEs and CEs after this class. And with that, Dr. Mackert, whenever you're ready, we can start sharing your didactics.
Sure. Well, it's exciting to be with y'all. It's always fun to talk to a group like this that's focused on such an important public health issue and kind of thinking about how health communication can be a tool in the toolbox to help address that. So I'm hoping to finish with lots of time for some Q&A. There's kind of 4 big things I wanted to talk about today. And one is I just want to very quickly define sort of health communication and the work that our center does. Give you and cover a couple of the tools and approaches we use in our work to develop more effective health messages. You know, and these are tools and approaches that can work across health issues. Going to share sort of a research and practice case study to show you kind of what it looks like when we go through the process of building good health messages. And then towards the end, talk a little bit specifically about some of the work that we've done and had the opportunity to do with the state related kind of COVID-19, substance use, and communication. So just really quickly about me, just so kind of my background. I came to health communication from very much kind of a e-health telemedicine background. And this website on the right, which is so old, it doesn't work anymore because it works in Flash, was a diabetes education intervention that was developed specifically to reach people who maybe had never touched a computer before, maybe couldn't read at all, and thinking about, you know, what is a really good health communication intervention look like and health education for people who really struggle with health information. When I landed here at UT Austin in the School of Advertising, I had never really studied advertising or thought about it a whole lot kind of academically in research. And I started looking, because of my health literacy interests, into prescription drug advertising. And one of the really common critiques about prescription drug advertising is they use emotional appeals to get a kind of a patient to go ask their prescriber for a very particular prescription, whether it's the right one for them or not. And one of the things that occurred to me kind of as a person who never really thought about before was, if you think about that differently, you know, a 30-second TV ad, a 60-second TV ad gets a patient so engaged that they talk to their doctor about a very specific health issue. In a lot of ways, that feels like a positive outcome of that conversation. But the role of emotion, I mean, I would teach my students how to use emotion to sell dish soap. And so the idea of like using emotion as a concern or a critique struck me as a little odd because that's what a lot of advertising is. And if you put it in the public health realm, no one really complains that you're using emotional appeals to help young people not start smoking with the Truth Initiative. So my own personal approach was sort of and kind of started to take shape around how do we take these tools and techniques of advertising and persuasion and emotion and put them in service of better public health messages. I use this slide in every talk that I give, mainly because if people come from a more medical or clinical background and they hear health communication, they tend to hear patient provider communication. And if I'm talking to people from more of a public health background, they hear health communication and they hear, this is your brain on drugs or tips from former smokers or kind of whatever the public health campaign was that they remembered the most. And so our center here at UT Austin is kind of defines health comm as the science and the art of using communication to advance the health and well-being of people and populations. So yes, it is patient-provider communication, but it's how do families talk about health? How do we talk about health on social media? How does a show like Grey's Anatomy change the way we think about health? All the way up to big public health campaigns. And the science component is particularly important because people can often think of communication as a soft skill. And our center is dedicated. There's decades of theory and evidence and literature on what really good health communication is. I have a colleague, she studies how do you break bad news? Like there's a best way to do it. She can train you in it. You can get better at it. And so when we started talking about evidence-based health communication, it created some really important common ground with kind of our colleagues and partners in medicine and public health and social work and nursing to kind of provide that bit of like, there's actually a lot of social science here that we can put into practice in service of kind of better health messaging. Our center, as far as we know, we're the only academic center for health communication in the country that is shared jointly between a college of communication and a medical school. We think of our work in three big buckets, and so there's lots of health comm research happening across UT Austin. We have some different training programs. I'll talk about one of them at the very end that might be of interest. But the majority of our work is in the practice of health communication and sort of our work implementing, designing, implementing, evaluating public health campaigns for the state of Texas, for UT system, for all kinds of different partners, is the bulk of what we do. And I'll be sharing kind of examples of that throughout the talk today. So in a talk like this, I always want to kind of give folks a couple tools you could use to kind of bring back to your work immediately and kind of thinking about what better health message design might look like. And so a really important part of that is changing the way we think about what good comm means. And it is not to create awareness. There is a fantastic article, if you Google it, it'll pop right up, called Stop Creating Awareness Already. And the idea is, when the world turns pink in October, it's not that it's bad to kind of think about, Breast Cancer Awareness Month, but we can do more than create awareness. We could, encourage people to get a mammogram. We could encourage families to have, conversations about familial risk of breast cancer. And so we really want to push towards behavior change everywhere we can, because that is really the gold standard of thinking about the way communication can support people's personal health and public health. This is a four-step process. It's not nearly this linear in the real world, but when we're thinking about our work, when I'm teaching students about this, we think of it as a four-step process to build a really good communication campaign. And the first step is research, which, it is often, surveys and interviews and focus groups and things like that. A really important step in research for a lot of our work is an environmental scan. Like, how have other people solved this problem before? What can we learn from other people's solutions? What can we copy and adapt? But the end result of a lot of research tends to be just a giant pile of data. And it is very hard to build a good communication effort on a giant pile of data. And so the second step that I think is the hardest is insight. So thinking about, what are 4 or 5 bits of data, insights into the audience we're trying to reach, where communication can really make a difference. And so it's distilling a lot of research and data down to some really key points around human behavior. And then we think about strategy, who are we talking to and what do we want to say to them? And tactics is last, which is, what does it look like on a billboard, on social media, on the radio, on TikTok? And people tend to go there first because it's the fun part, it's creative. But if you don't do the first steps, those tactics are going to be all over the place. And so doing the first steps is what eventually leads to a number of tactics that are all going the same direction, work together to achieve your goals, which is why we start always with kind of that research and insight before we even get to the messaging and tactics part of things. One of the tools we use a lot, I teach my students about this. I think it feels a little high schooly when I first tell students about it. But these are really important tools that get used to build, giant advertising campaigns. And one of them is personas. So when I'm teaching advertising students at UT, I do at least once a semester a project in partnership with the campus public health office. I think it's really helpful to contribute to campus health. I think it teaches the advertising and PR students that the things they're learning can be kind of used in service of health and health promotion, not just selling goods and services. And so one particular semester, the on-campus health office said that their goal was it was a skin safety campaign. So do use sunscreen, don't use UV tanning beds. And one team put up this as the audience they wanted to reach. Now, this is a direct copy and paste off the student slide. In our work, we try really hard not to say target audience, and we prefer to say intended audience. And that's mainly because intended audience still is like who we are trying to reach, but it also serves as a reminder there's unintended audiences for everything we put out into the world. And so it helps you kind of keep in mind, who are unintended audiences, what might be unintended effects. But still, this team, worked for 5 or 6 weeks, and they get up to do their presentation, and they say the audience they're going to reach is members of sororities on the UT Austin campus who are 18 to 22 years old who use tanning beds. Like, this is a reasonable answer to the problem they were handed. This team developed a lot of messages around kind of skin cancer prevention, and it felt okay. The next team got up and did what I had been kind of coaching and trying to get them to do. This was their very first time trying, and they actually used a persona. And so the idea of a persona is to create sort of a composite of your data. It's not meant to represent everyone in your audience perfectly, but it's meant to be kind of like a person who's pretty representative of the audience you're trying to reach, but to put a human face on that person. And so this team kind of put up their slide. They said, we're going to reach Rachel. They told us about the sorority she's in, the brands she likes. If you look on the right, you can see she stays fit, eats healthy. She goes to a dermatologist and is aware of the risks of UV tanning. But she thinks tanning makes her look thinner and have a better complexion. And so this team explained, telling Rachel again, UV tanning could lead to skin cancer is not going to help. She already knows. She does not need to be told again. This team started to think about other ways you might talk to Rachel about skin safety. Does it mean you UV tan less? Does it mean you swap out some UV tanning for a spray-on tan? Does it mean you remind her of a time that she was in the tanning bed too long and came out really burnt? Like, there's a lot of different ways you might talk to Rachel if you think about her as an actual person you're trying to reach and have a conversation with. And so then if you think about that, that turns into messages that would work well on a lot of people who are like Rachel. So persona is one tool you can use and think about using in your health promotion work. The second thing is how we frame problems. So I like doing this, anyone who's in a webinar like this, you care a lot about the particular health issues and the audiences you work with. And it becomes hard sometimes to think about a health issue the way a normal person does, a person in the audience you're trying to reach who probably don't think about your health issue constantly. As an example, we've done work just on campus and in my classes on how do you get people to take the stairs to the elevator? And if you give that question to people from more of a health background, they tend to think of messages that are a lot like this. You could burn calories, you could get some steps in. Like, it's a very health, fitness oriented message about take the stairs and not the elevator. The other thing you could do is remind people of why elevators are terrible. Like, they're slower, they can be crowded, they can be like an elevator in the Texas summer with people who are talking on their cell phones and sweaty. Like, this is not fun. If you test these, the ads on the right do better to get people to take the stairs compared to the ads on the left. They also do much better if you pull the ads like 200 feet in front of the elevator before people have decided what they're going to do. And so it's not just what message do you want to give them, it's how you're framing that message. It's also where you put the message makes a big difference. And so in the work that we're doing, we start thinking about what are all the different benefits of behavior change. And what are the ones that really matter to people? Like, I don't need to convince a person to kind of make a health decision or take a health behavior for the reason I think is most important. Like, if there's something else that might matter a lot to them that will help them make a decision that would support their own health, I'm very happy to help get that message in front of them. So we think about framing the problem depends a lot again on that audience understanding and insight and understanding what would really shape and change their behavior. Um, Next to last tool I'll share with you is the single most important thing. I will coach my students and internally work on it really hard that if you cannot get down to a single sentence what you are trying to say, I am going to argue that you don't actually know what you're talking about yet or what you want to say to people. And in the audience, if you can remember the old Verizon "Can you hear me now" guy, where he was an engineer with the big like, kind of black glasses, wandering the country, talking to his cell phone, just saying, "Can you hear me now? Can you hear me now?" over and over and over again. That's like what that whole campaign was. And I had a chance to meet the creative team that built that campaign. And they said it was actually a single word that drove the entire nationwide Verizon national advertising effort for years. And if you reflect or think for a moment about what you think that word might be, usually what people start thinking about is speed and coverage and reliability. You start describing what a good cell phone network looks like. The actual word that drove that entire campaign was relentless. They wanted to communicate that Verizon was working the hardest to make their network the fastest, the most reliable, the best coverage, all those things. And so if they shot a 60-second TV ad and it did not communicate relentless well enough, they would redo it. And so that was the real take-home message was Verizon's working harder than AT&T, Sprint, and T-Mobile to make their network the best. And it led to a really effective, consistent message they delivered in a lot of different ways, but always with relentless at the heart of it. And the last thing that we think a lot about as a center is how we are going to test our own ideas and kind of double check our assumptions. So I'll give you two examples of this. We have an app called Father's Playbook that is meant to engage expectant and new dads in prenatal health and early childhood. It's sort of the dad to be equivalent of My Pregnancy Today. And My Pregnancy Today does a lot of things really well. Your baby's as big as with, food metaphors with, a grape and an orange and all the way through. It's great. And it's a really good, clear communication approach. In thinking about what the dad to be version might look like, we were exploring would a sports metaphor work better? Your baby's as big as a golf ball and a tennis ball and a softball, all the way up to a bowling ball. And we tested this with a nationwide sample of expectant new dads. And the food-based metaphors win like 65 to 35%. And when we asked why, the respondents tell us that the food metaphors help reinforce the importance of proper nutrition during pregnancy. We never would have guessed that. And if we just followed kind of our assumption or hunch, we probably would have done the sports thing and we would have been wrong and for a bummer of a reason. And so like we always want to double check our work and kind of follow our data where it might lead us. In a case like this where there's kind of two competing ideas and we might think we know the answer, but let's still double check and see if we're right or not. The ads on the right here are an example. This is work that we've done for the state around prescription opioid misuse. And in year 2 of the project, the state wanted us to build a video for caregivers. So someone who might be concerned about a loved one, a friend, misusing prescription opioids. And we had a postdoc on the team who was an interpersonal expert. And her idea was there's kind of 2 patterns of family communication around health issues and all kinds of issues. And one is very direct, where you're going to go to the person you're concerned about and say like, hey, I'm concerned about your prescription opioid misuse. That's the way it goes. There's other families or relationships where it's very indirect. It's like, I was watching House MD. Sure seems like that guy misuses prescription opioids. Like, what do you think about that? And you kind of like look at the person sideways. And we wanted to test in this video, if we were going to depict a conversation, should we depict the direct or the indirect version? So we created storyboards in the animatic version using both and then tested it. And we found was the indirect style worked much better to include in the video. And that's mainly because if you show that very indirect form of communication to someone who is direct, they're like, I don't need to pretend, I'll just talk to the person. Like they can skip over the indirect example and just go to how they know they would do it. If you show the really direct version, that kind of person who favors the indirect style is like, oh my gosh, I could never talk to someone like that. And they don't automatically think of how they would do that indirect version. So the indirect example is really helpful for getting sort of more indirect inclined people to want to have the conversation or feel like they could have that conversation. And the direct people don't care because they're just going to talk to them anyway. So we tested two different ideas, found the one that was going to work the best. And then so we adopted that more indirect style in the video we created. Okay. Um, I want to share with you kind of a case study of what this looks like and behind the scenes how we go about this work. Because usually you just see the end thing and don't know all the work and research and ideas that went into this. And it shows you kind of how messy and how many fits and starts there can be and how many failed ideas you generate before you get to the ones that are really good. So this particular project is something that we did. It was funded by the University of Texas System. And the goal was going to be to help create a health comm campaign to help students kind of better understand and communicate about the intersection of alcohol and sexual consent. So at all the UT system academic schools, so UT Dallas, UTRGV, all of them, all those campuses do high risk drinking prevention work, and they all do a good job of it. On all those campuses, they also do sexual assault prevention work, they do bystander intervention promotion, and they all do all that work really well too. But when we started this project, there was a little bit of a gap where both those kind of programs and efforts sort of pretend the other wasn't going on, and there wasn't obvious overlap. And it's because it's very, very hard to talk about that intersection, that gray area, without getting survivor blaming pretty fast. Like it's very hard to do that comm work well. And so everyone was sort of just hesitant and didn't know how to do it. So UT System came to us and asked us to do this. It was going to be a little over 3 years as a project. And the whole first year was going to be nothing but research. No project ever gives us the gift of a year to do nothing but research. But UT System did on this one, and it was much needed. We knew this was going to be hard. They knew it was going to be hard, and we were going to need to do a lot of research along the way to kind of get to something that was going to work well. So in this project, we did one of my favorite ever research kind of tools we've used was what we called our drunk scale. So imagine this like really stacked up 1 through 10. It just doesn't fit in a PowerPoint slide that way. But we took sort of the BAC chart you might see. And on the left, where normally you'd see 0.00, 0.02, 0.04. We had undergrads working on the project. And we said, what would you call these 10 levels? And so they named them, totally sober, to loose, to buzz, to tipsy. In the middle, we have, physiologically what's happening to you. And on the right column, we have like, what does it look like in a student's life? And so if you are feeling it, judgment and self-control are lost, motor skills are impaired, and balance may be compromised. What it looks like as a student, dance like no one's watching. Oh, you've already been doing that. Do not get behind the wheel. And what we then asked students to do in a survey was we asked them, where can you be on this scale and give or receive sexual consent? And the early research on this project was being done on the UT Austin and UT El Paso campuses. The early research was a little under the radar. We were very concerned in the early steps that we were going to be building messages that weren't going to be right. We were scared about people screenshotting mock ads, and we were very cautious on like the first steps of research. And so we were doing the early research in a little bit underground, reaching out to faculty, inviting students via Canvas. And so the data we got in the first round or two of data collection, we knew wasn't going to be totally representative of the full campuses, but it was a better way to get the early ideas going. So all the bar charts, don't worry about them. The story of our data is young male identified participants in our sample are on average pretty much exactly 1 drink higher than the young female identified participants in our sample. So there's like a 1 drink gap throughout. And when we think about what an insight is, where communication can make a difference, knowing there's this 1 drink gap between students in this way is the kind of thing that we think we could build probably a really good health message around. So I'll show you we were doing surveys, we were doing interviews, we were talking to key stakeholders. I want to show you a bunch of first ideas that we developed based on different insights in our data. So we were doing this bit of data collection around the time of the Justice Kavanaugh confirmation hearings. Like it was really intense and hard. And a couple of the students working on the project wanted an idea that was sort of like anyone could be a perpetrator, anyone could be a survivor. Like let's invite everyone in and then do the hard work of what we want the campaign to do. So it was this very like Humans of New York visual style, like pictures of just individual students, a story, and let's see if that might be a way to kind of get students to engage on a really hard topic at a really fraught moment. We asked students how can you tell if someone can give consent? And their answers were basically, I can see it in their eyes, I can hear it when they're talking, and I can tell if they're, wobbly or not. And so we took those heuristic students were using to make decisions and judgments and said, it's not disoriented, it's not staggering, it's not vomiting, it's coherent. That's what consent is. We had two ideas that were built on students were very clear with us that they knew this was a two-sided conversation. Even two people who are trying really hard to talk about this still might not be communicating perfectly. And so there was this idea about kind of like a two-sided conversation, two people being on the same page, showing a little bit of the back and forth between two people who might be talking about this. I mentioned that our first sample was not representative. It was really cis heteronormative. So we knew this isn't how it was going to end up, but this is the very direct literal translation as a first step from our drunk scale finding. So your drunk is her totally wasted. I'll show you how that one evolves. It gets a lot better as we go. We had a question about whether if two students meet for the first time at a bar or a party, and one of them starts talking about the intersection of alcohol and sexual consent, is that a good conversation? Like, does that feel like, oh, this person gets it, I trust them, they know this is complicated? Or is it like, oh, this person's been in trouble, I need to get away from them? And in our data, it was overwhelmingly viewed as a trust building conversation. We didn't know how that would be. And so if a bunch of students are hesitant to talk about this because they're concerned about how they might be perceived, we can assure them, like, actually, this is a good conversation to have. Your potential partner will appreciate this. Let's make sure students know that. And last, I mentioned that, we were doing this during a really hard time, and students themselves were telling us, make something lighter. And so I had some students in a class doing this, they were going to do in 5 weeks what we were going to do in 3 years. And one team had this idea of using like emojis as a visual style to have just like a slightly lighter tone to the idea. I'll tell you, as soon as we put the UT Austin word mark at the bottom there on the right, students were like, absolutely not. Like, this is old people trying to sound young. And I was like, this is directly from students down the hall. Like, we just like made it look a little bit nicer. But as soon as we put that UT Austin logo on the bottom, this idea was a no-go. Like, it didn't feel right to them. And so this was definitely not going to work as like trying to have a slightly lighter version about this topic. Okay, so as we start, like, we're talking to students, we're doing more data collection, we're talking to the steering committee for the project. So we start getting rid of ideas that aren't going to work for different reasons, and then trying to make the ones we like better. So these two kind of keep going. They don't change much. Here you can see this idea was, as we were trying to, again, think about something a little bit lighter, because students were asking us for that. We were like, if we want students to think of kind of alcohol and consent as like a pair of ideas to have in their heads, what are other classic pairs like peanut butter and jelly? And so we started trying to have this idea of like we could imagine these little characters being like little tchotchkes on their backpacks. This was by far the most fun one to work on, but also like led to the most ridiculous conversations. Like, there was an assistant vice president for the university on our steering committee, and he's like, why is that jelly concussed? And like, just it was fun, it was silly. Like, a lot of people thought this was like a really fun one to work on. And it was kind of a first pursuit of another attempt at something a little bit lighter. Here you can see we have taken the gender out of the pronoun. So your buzzed is they're totally drunk. We talked a lot about color on this project. It is almost impossible to pick colors that people don't attribute gender to. Like, humans put gender into basically any color. And the eventual colors we pick have to work well with the UT system schools color, like branding palettes, which are a lot of blues and reds and oranges. So one of the other things that happened when we did this, though, is when we had for months and months and months been thinking of this as two potential sexual partners talking. As soon as we turn into your buzz is they're totally drunk, there was this other reaction students started having, which is like, oh, I should talk to my roommate before we go out. I should debrief with my friends the next morning. It was like just a very different conversation sort of appeared that we weren't counting on. And so it was great. Like, it was an accident of making the campaign more inclusive in the language we were using, opened up like completely different conversations than we had been thinking about in the first months of the project. And last, we added a new idea at this point, which was students themselves were like, are there just like magic words I should memorize? Like, they really thought of it as like a quiz almost. Like, they really wanted to get it right and do right. And so we had this idea of like a flashcard idea. These could be coasters placed in bars or handed out for use at parties. that could include really important concepts, example language. And this emerged from, again, from talking to students as we went and kind of being like, oh, they really just want to do this well. And if we can give them the tools and the language, like they're going to pay attention and learn. So one last round of polishing. We keep the two-sided conversation. Here you can see we kind of take the concussion, stars off the jelly. We add little red Solo cups and beer bottles because it was really important that students understand this is about both alcohol and consent, not just one or the other. That was the goal of the campaign. Here you can see we add alcohol as a visual into showing the different levels of alcohol consumption. And finally, we keep this. So if you want to, for a minute, if you want to throw in the chat window, if there's any particular idea you think is a winner, I need just a drink of water really quick. And so by this point, we feel like these are all 4 ideas. We have enough data and evidence and kind of feel good enough about that we feel much more comfortable putting all 4 of these into a more public facing survey to get a broader, more representative kind of data set from the 2 campuses we were piloting on. So we do this round of data collection. Here's what we find. This two-sided conversation thing it was just kind of more well received at UTEP than UT Austin. We have no idea why. And students at UTEP who saw this particular message were more likely to express higher intentions to communicate. So I said earlier, we don't want to create awareness that their sexual consent and alcohol consumption are related. It's not that. We want students to be more likely to communicate about this. So this campaign is like a nice sign that maybe, at least at UTEP, better or higher intentions to communicate. Fantastic. The kind of drunk scale inspired idea actually moves students down the drunk scale. So students who see this idea, if they originally thought you could be feeling it, maybe just up to tipsy. If you told us, 18 months before this, that we would build anything that would move students down a scale like that, we would have taken that as a win all by itself. But also students who see this idea are more likely to think it's only about the alcohol part of things. So there's that. This classic pairs idea tests terribly. We had a variable called tone. What's the tone for a good campaign about this topic? What's one of this particular concept that you're looking at? And this one is it's just not serious enough. And so we don't know. We built the 2 lighter ideas because students were telling us they wanted a lighter idea. We don't know if what that means is we just like students really think they want it until they see anything that's lighter and they're like, nope, this is too serious. We don't want to light campaign on this. Or it could be that we never perfectly captured that right balance where we took a lighter approach, but still made it serious enough. So we had to very sadly get rid of our most creative, fun concept to work on. And then the flashcard does awesome. It does all the hard communication work we want it to do. So students are more likely to kind of have higher confidence ability to communicate, lower feelings of awkwardness, greater intentions to communicate. And people really get this idea is about both alcohol and consent together. So what it means is that we take the drunk scale little icons, we pair it with that flashcard idea, and now the flashcard content becomes the like conversation bubbles. And this is what the campaign starts to look like. And we imagine what would it look like on A-frames and all over campus. We were planning on implementing the campaigns while all the students were off for spring break 2020. And then doing a pilot evaluation the second half of the spring 2020 semester on campuses. So that obviously did not happen. This whole campaign and project got put on hold by COVID for a while. Eventually, it got piloted digitally first because as much as students might not have physically been on campuses, the issues were still really relevant. And it has since fully been kind of rolled out. We've provided all the toolkits and all the resources for all the different campuses to put this campaign into action if they want to. I have a couple more things to share before we get to the Q&A. One is this kind of work and the way we approach it cuts across health issues. So we've done work on prescription opioid misuse, substance use disorder, tobacco cessation, hand hygiene, HPV vaccination promotion, children's mental health, across all these different issues, like the principles of getting good data, understanding your audience, testing ideas, like it cuts across everything that we do. And so even if the examples I use today aren't like perfectly aligned with what you and like you as participants might be working on right now, the principles and the tools definitely can be kind of adopted and used to support that work. Um, Specifically around COVID-19 and substance use, we were approached by HHSC to do a campaign that was going to be a very upstream substance use disorder prevention campaign. And the goal of the campaign was really going to be promoting social connection and healthier coping strategies. And our specific part of the work was going to be to build a kind of interactive screening tool. So people could go in, answer some questions, and then get customized resources to help them. This campaign is currently running across the state right now. It's called Turn Two. And so I have an ad here on the right. You can see these on billboards and buses all over the place. I still get happy when I see one drive through the UT Austin campus. You can see here some of the key intended audiences we're trying to reach, the website down there at the bottom. The check-in tool itself that we were responsible for designing, it's available in English and Spanish. It's available for yourself or to take for someone you're concerned about. And the modules kind of have there's four main modules of content in the questions, and it's basic demographics, mental health, social connection, and substance use. And once people take the check-in, then we give them resources that kind of fall into three main kind of areas. It's substance use, mental health, and other stressors. You can see the whole list here. Every one of these, if you check the right boxes, then you get the customized tools that make sense. And then some conversation guides, because we know this is hard for help. It can be hard to ask for help. It can be hard to offer help. It can be hard to reconnect with someone you haven't talked to in a long time. And so we're also offering these tools to kind of how to have this hard conversation. And you can see here, this is from basically the May to May of 23 to 24. You can see almost 50,000 Texans have taken the check-in for themselves. You can see kind of where they're spread across the state. And then in the exact same time period, around 3,000 people have taken the check-in tool for someone they might be concerned about. So there's much more, obviously, attraction and interest in use of the tool to check in on people themselves, which then behind the scenes means we could put more resources into promoting that, since that's where people are already going, to get more and more people to take in that self check-in tool. Last thing I'll share with y'all, and then have enough time for some Q&A here at the end, is I mentioned our center has a bunch of different education offerings. We have a minor for undergrads who are undergrads at UT Austin. We also offer this health communication training series. And so the courses are built in partnership with our partners with the Texas Epidemic Public Health Institute. There's currently 3 courses that are online through this TEPI group. All 3 of these courses are free to take. It's part of their work to kind of build workforce skills and resilience around better health pandemic preparedness. The other reason I wanted to share this with you all today is if you take any of these courses and complete it, you can actually get a code to take another one of our online ed courses for free. Some of the courses we charge for to kind of help cover just continuing ed costs. But we have a course that is about how to have hard conversations about pain and opioids. And so it's co-taught by a patient provider health comm expert and a clinician from the med school. And so she can both teach you here's the principles, here's the way you would want to do this. And then he explains this is what it looks like in my actual practice when I do that. We have courses on the role of emotion in health communication, the role of visuals in health communication. So if you're interested in kind of some of the things I've talked about today have sparked some interest in learning more, these courses and some of the other courses we offer through our online ed program just might be of interest. They're all meant to be taken between 30 and 60 minutes. So they're very digestible chunks of health comm skills training. I'll put this up here. Here's my contact information about our center. Again, I really appreciate the invitation to talk to you all today, and would love to have a Q&A and talk about anything that you thought was interesting, or other questions about kind of what good health comm might look like. So thanks again for the opportunity to be here. I will stop sharing my screen so we can see each other a little better maybe, but happy to be here and happy to answer any questions you have.
Okay, this is just such a fascinating topic, I must say. Very, very interesting. It to me kind of it overlaps, or it encompasses communication, marketing, health information. It can go to so many different rounds and in so many different ways. It's fascinating. And we do have some questions here for you, Doc,
Mhm.
if you don't mind.
Sure.
Someone here says there were contradictions and uncertainties during the last COVID-19 pandemic. How can we prepare ourselves in case of a new outbreak? Or who should we listen to in these cases?
Sure. So I have two thoughts on that question. I can see a couple others here in the chat too. I mean, so well, COVID was the world's like worst health com challenge. So even people who were doing it really well still ended up being wrong because we just learned things. Like I very much remember the month or two that like we were lysoling our groceries because we thought maybe that was a thing we needed to do. And then we learned it was airborne. We weren't. Like it doesn't mean the people who told us like this might be a good idea. It doesn't mean they were wrong. It means we learned something new. And so I think during COVID, one thing is if we could do it over again, I think doing a better job for people who are in public talking about these kinds of things, doing a better job on like, hey, this is the best we know right now. This might change. Like, I think the idea that what we knew was going to change was just not as present in most people's messages as it could have been in terms of the way recommendations were going to change as we learned more. So that's one thing. I think in terms of like contradictions in terms of what people were telling you, there was a moment I remember I was being interviewed by a reporter, and it was when the World Health Organization hadn't yet publicly like announced like it's definitely airborne. And there was a letter that was signed by like 100 like prominent faculty researchers at like it's like people from Harvard and Princeton and all the places. And it was like virologists and air quality experts, and they were like, this is 100% airborne. And they were pushing the World Health Organization to make that like definitive. And the reporter asked me like, who should people trust? And I was like, both. Like they're both doing their jobs. Like COVID shoved in front of people what normally is like a slow process behind the scenes over years with like academic research and blue ribbon panels and like all that just didn't happen. And so, the academics were pushing with what they thought was right. And the World Health Organization was doing what it's probably supposed to do in that situation, which is like, well, like let's make really, really sure before we make that statement. Like they're both performing their actual roles just in public and faster than ever before. And so it wasn't you shouldn't trust either. And so my advice was like, if you are inclined to be more conservative, follow the scientists. Like nothing bad happens if you kind of are more conservative, and that's what helps you feel better. So in some of those cases, following kind of what might be a more conservative guidance felt like it might be not a bad plan. Um, I think the idea of fostering promoting credibility when new information is being transmitted, a lot of that is being set up before you need the communication channels and the trusted folks in the community to be sharing your message. When those early days of COVID, I mean, like I followed DSHS on Twitter because I'm me. Normal people did not follow Texas Department of State Health Services on Twitter. And so, like, how they could partner with people in local communities, trusted community leaders, like, that's how they needed to get the word out to a lot of Texans, in our case, who weren't going to be following Texas public health messaging and social media in quite the same way. I think in some cases, they probably had really good partnerships through other campaigns they worked on. In some cases, they probably didn't have the right people in place. And so, when you think about how you can foster trust and credibility in the community, it's like having those people on the team ahead of time. So when you need them, you are ready to kind of tap into those trusted networks to help good messages spread because you already have the people in place. Like that's just a preparedness thing that I hope we do better um, the next time. And in terms of the third question there about misconceptions on persons who use substances and stigmatize them, we have a lot of interesting work and findings about this, and I'll mention two of them. One is when we did our prescription opioid misuse work, we can get statewide surveys of like people who remember our campaign versus who didn't, and then compare them. And people who remembered our campaign were higher on all kinds of things that we cared about, like more likely to throw away unused opioids, more likely to think like they were higher on a bunch of outcomes we would have wanted. They also were like slightly higher on stigmatized beliefs about people who misuse opioids. And we saw it and we're like, what the heck is that? Like we were like, honestly, like we were shocked. We were like confused how the campaign, like how what we had done could ever contribute to that finding. And so we talked to the state and we're like we're not going to hide the fact, like this is a finding we got. We talked about a couple of theoretical reasons might be happening. We made some changes to add some more direct like anti-stigma components to what we were doing, ran the same survey the next year, same exact finding. So the current work we're doing is like specifically like digging deeper into that finding. Like, is it just like if you have a personal history or something that happened to you related to prescriptions, like does that like it just makes it salient again and reminds you of that like there's a lot of reasons it might be happening. We also found an almost identical finding in some substance use work, not opioid use work, which now leads me to wonder like, do people find this a lot and just never tell anybody? Like we might have found like a really consistent thing that happens, but no one ever talks about it, which isn't great. Um, and the other thing that I think is relevant here, maybe, is in terms of the language we use. I was doing some work on campus with it was the Addiction Research Institute, and they were having kind of a conversation about like should they continue to use the word addiction in like their work, like how like what that meant as part of like the way they were talking about it. And some of the faculty, some of the public health people were like much preferred, people with substance, like they preferred like person first language and those kinds of things. And one of the community representatives was like, nope, I'm an addict, like that's how I identify. Like it was really important to that particular person, like that word meant something different than the way the public health side of the team was like thinking about the way that word might have negative impacts on some people, which just makes this really complicated. And it's like in some cases, there's not really a right answer. Like I agree with the public health people and first person, first language, everywhere you can do it. But like if the other person's like, no, this is like part of my identity, it means a lot to me, it helps me stay sober, like I'm not going to argue with that. And so I think in some cases it means that a lot of people who are on the team and all want to work in the same direction just have to understand the language and some of the things that we're going to say just aren't always going to line up perfectly, or there's no real easy answers in some of these.
Yes. And then we have another one here specifically, and I agree a little bit with this because I've always found like the ads, the campaigns for non-smoking, in my opinion, some of them are a little disturbing.
Mm-hmm.
And do they really work? Because it seems that that hasn't changed. So it looks like that message is getting somewhere because it has been years and I keep seeing the ads are very graphic. What would you say about that? Is that an effective way to communicate in that case?
So, like I know specifically the Tips for Former Smokers and the Truth Initiative are two of the most well-evaluated public health campaigns ever. I mean, they were like huge resources into the like running and like making them work at scale, more like a traditional advertising campaign, but also a lot of research behind the scenes on those campaigns. And there is a lot of evidence that Tips from Former Smokers and the Truth Initiative both do a lot of really good work to help people quit smoking, to prevent smoking. Like they work great. Um, I think two things I would mention on that if you don't spend a ton of time thinking about health communication all the time is one is um, the difference between a fear appeal and a disgust appeal. Like those are two different things. They have different impacts. It's why I mentioned that we have one of those online ed courses about the role of emotion in health communication. So there's people who like actively are studying and working on the difference between a fear and a disgust appeal. And in some cases, disgust around, say, smoking actually works better than fear around smoking. So some of the tips from former smoker ads that do the best are the ones that like most play up like a disgust component to the message. All those messages also do better if you compare them with a positive emotion like hope. Um, so the way emotion works in health comm is kind of nuanced. And the other thing that I'd say is a lot of times before people really dig in, they tend to think a memorable message is an effective message because you remembered it, it must have worked. And the example I always use to kind of prove why that's not the case, like everyone has seen campaigns about not texting while driving and like grisly car crashes and all kinds of things. You can remember things you've seen like that. Like tons of people who've seen those ads still text while driving, usually because 2 days later it's like, but I'm good at it, not like the person in that ad. And like it just doesn't have a lasting impact. And so one, memorable does not make it effective. You can remember something for a long time that didn't work at all, to change your behavior. And then, it's thinking about we spend a lot of time talking and thinking about like where communication can really make a difference versus where like there's a better tool out there and it's called public policy. And like let's not pretend we can communicate our way out of something that is fundamentally like a policy decision that needs to be made to make the change we really want to support in the world.
Good. I see. I have here another question. It says, oh, this is interesting. What are the most prominent lessons learned from communication during the COVID-19 pandemic? Or what should we consider for next time if this happens? So, did we learn something for the
Um,
next wave?
yeah,
Hopefully not happening.
I think we learned a lot. Whether we're going to use it all again the next time, I'm not sure. Like the idea of trusted messengers and some of those things. Like we technically knew that before. We just didn't always do it when it was happening during COVID. I mean, it's the Crisis Emergency Risk Communication Manual from the CDC. It was like last updated like 15 years ago. It's still all right. It has all the right ideas. We didn't use the playbook as well as we probably could have. Um, I think there's something I like personally wish we could have done better. It would have been, I think, very early on, we didn't do a very good job like remembering that we don't have to get people to care for the reason we care. And so if we could do it all over again and had just settled on like be free of COVID as our message, be free of COVID, be like, I might want to be free of COVID so I don't die or my grandma doesn't die. Is someone else could be free to keep the schools open, someone else could be free to keep the bars open. Like I honestly don't care like why you care, as long as we're a little more on the same page with like some of the preventive may like if convincing everyone that wearing masks would have helped us be free of COVID, and free of COVID could mean lots of things to lots of people, we might have had more people wearing masks better for a longer period of time. And so I think if this happens again or when it happens again, I think a little bit more attention to like, let's help people make the decision in ways that align with their interests and values, and a little bit less, I'm going to convince you to care why I care. I think we probably could have done a little bit better job. To Andrea's question here, I'm personally extremely interested in the role of kind of like AI in doing message generation and also message pre-testing. So I'm really curious about like if we want to build a public health campaign, we'll use wastewater monitoring. Like it's a big public health tool related to kind of COVID. If you want to develop a campaign to help people in a local city, like be like, it's great that our water treatment facility is doing wastewater monitoring for like public health like monitoring. You could say like, give me 20 ideas of how you'd communicate this to people. And it will definitely generate ideas. I mean, some of them are really good. Some are things that I think anyone in this room probably could come up with. It definitely will generate ideas that might not quickly occur to you. And so I think it can be a really helpful tool to do like lots of idea generation quickly, as long as there's a human sitting between the ideas and the general public. I think, you can ask the tool like that to say like, hey, respond to this message the way Andrea might. And it like you can ask it to respond like a 50-year-old conservative in El Paso, and it will try and respond like a conservative 50-year-old from El Paso. And so like one of my hopes is we can build better tools to sort of simulate audience response to get quicker versions of like what's going to work or what's not, or what are people going to get mad about. I think we could do a better job. And in the health literacy framework, that's one of my interests, those tools are great at plain language ideas. And so if you're working to try to get something you're working on down to a lower grade level, it's a really helpful tool to kind of put the text in, say rewrite it at grade level X. And again, there's an actual human expert between the tool and the public, and it will almost always generate at least a handful of ideas that like I haven't thought of, or that we haven't thought of in our work. And so it can be a really clever, easy way to kind of do some of that work that everyone's always trying to do. And so I hope it can a little bit, I'm a little more on the cautiously optimistic side of AI and its role in public health, but it can really, I think, democratize some of the message generation refinement that right now, if you're like the one person at some local health department doing this, like it's hard to do all this by yourself. And so I think those tools can be a nice supplement for people doing this kind of work.
Of course, definitely a great help. But like you said, with the human element in the middle to kind of filter and improve whatever results we obtain from AI.
Yep.
That's for sure. So this has been a great presentation. I really would like to see a part two. In the interest of time, we're going to be moving to our announcements. Thank you once again, Dr. Macker. That has been, I mean, this has been incredible. I mean, very, very interesting, fascinating topic. We hope that we see you again at one of our seminars or at our echoes. And thank you again. We're going to move very quickly to the announcements. And remember that the Center for Substance Use Training and Telementoring CSTAT offers technical assistance. And technical assistance can be clinical mentorship or case consultation, connections to organizations or resources in the community, information about how to distribute medications for opioid use disorder. So anything related to substance use disorder and telementoring, we're here to help you. There is a form in our website. Once you complete that form, it should not take more than 3 days for someone to get back to you. So to request a technical assistance or TA, please complete the online request at cstat.utesca.edu. Next. And just a reminder, and also as an invitation to a wonderful Dr. Mackert, a great speaker today, we have 8 different sessions at our ECHO program right now. And each one of these sessions addresses a different aspect of substance use and substance use disorders. So we invite all of you to go to our CSTAT website and sign up for these sessions. When you sign up for the session, you also have the ability to download the invitation on your calendars and receive reminders so you don't miss any of our sessions. So if you want more information about any of our 8 series, part of our ECHO program, please go to cstat.utesca.edu. Next. And remember, we're offering today CMEs and CEs. And for CMEs, the process is very simple. You're going to be texting code ATTEND 100 95897 to the number that you see on the screen. Please make sure that you text that number today before midnight. If everything goes well, if you're registered with the system, you should be receiving your CMEs via text, no problem. If there are any issues, please send us an email here at BWell Texas, and we'll help you. And regarding CEs, and I want to make that difference for some of you, the Cs, we're referring with that to the certificate, their certificates, I'm sorry, for behavioral health professionals. For those, all you have to do is complete the post-session survey. Be on the lookout for that survey after this class. Once you complete this survey, please give it approximately 2 or 3 weeks for us to email your certificates. So there you have it. It's very easy, but if you have any questions, please send us an email and we'll be more than happy to help you with that. Next. Okay, so our next session for this same webinar, it's Wednesday, July 10th. We're going to be presenting telehealth for behavioral health services. Someone who's very appreciated by us here at CSTAT, Dr. Leslie Manson. She's going to be talking about this very important topic. If you want to register again, go to our CSTAT page. That's telehealth for behavioral health services on Wednesday, July 10th. Thank you. We'll see you there. And once again, we want to thank all of you for taking part of this webinar. Be on the lookout again for that email with your post-session survey. Your opinion and your takes and views on these sessions are extremely important for us. So thank you once again, and we'll see you next month. Thank you. Have a great rest of your day. Bye-bye.